А?
Прикрой двери, а то мы громкие все.
Ага, да-да-да. Только я не вижу, что она у меня пошла. Good afternoon. We'll continue to talk about renal syndrome, and today we'll finish our information with diagnosis of renal failure. Renal failure is dysfunction of kidney which manifested with disordered its main functions. Она застыла и все, не двигается. На боковую кнопку.
Да, стрелочки вперед-назад.
Хорошо, спасибо. Renal failure divided on two. Да? Я закрыла, Excuse me, any technical problem. Renal failure, as you see from this slide, divided on two types, acute and chronic, depending of time appearance and preceded anamnesis. Acute uremia usually appears without preceded kidney anamnesis and appears as a result severe affection of kidney parenchyma and its main functional units due to poisoning with some nephrotoxic substances. It may be mercury, lead, carbon or barbiturate. It may be result of transfusion of incompatible blood because in this case erythrocytes actively destroyed due to hemolysis and obstruct renal vessels to stop its functional activity, because you understand filtration of urine is possible due to adequate blood flow and definite blood pressure. It's explained why profuse hemolysis and shock also accompanied with acute uremia, kidney excluded from its functional activity. Chronic uremia, chronic renal failure is the result of non-effective treatment of some chronic pathology or its progressive gravity. Early it appears of the patient with chronic glomerulonephritis because this pathology involved both kidneys simultaneously in pathological process. Slowly chronic uremia progresses in chronic pyelonephritis, nephrosclerosis or growth of tumor. Let's give clinical characteristic every type of renal failure, because on exam it will be given in different tasks. If we are talking about acute renal failure, during its development we can distinguish several stages. First, initial stage when the signs of renal dysfunction are visible and all attention of doctor will be paid on primary pathology which not connected with kidney. Second stage becomes visible because patient and doctor can see progressive decrease diuresis to oliguria when the amount of filtrated urine becomes less than half liter and complete absent urination, anuria. Then maybe third stage when the kidney activity again come back and filtration of urine presented, but it's not controlled completely. We are talking about polyuria. And fourth, recovery stage. First initial stage, I said you, it's invisible. Doctor pay attention on main problem. It may be trauma, or it may be shock, it may be some infectious disease, poisoning, myocardial infarction, any grave pathology with which patient enters in emergency department. and during some hours or sometimes during 1 week, kidney may be secondary involved in pathological process and its activity stop. To early diagnose this process, together with main diseases, doctor obligatory must control functional activity of vital organs. In our case, it will be kidney, which may be controlled due to control of diuresis first of all, and level of toxic substances which must be removed with urine and characterize functional kidney activity, creatinine and urea. If we lose this process or pathological process progresses, patient go to next second stage, oligoanuric. Amount of urine progressively decreases and completely stop. If no urination, all toxic substances will be held inside the body and clinical manifestation will be with progressive intoxication and water electrolyte disorders, because it's also controlled by urination. How can you know about intoxication? Patient feels vomiting without any positive effect. Will be problem with consciousness due to response of central nervous system on intoxication. Will be problem with activity of the lung and heart. Will be increased blood pressure, and we can see progression of edema because liquid hold inside the body. Oligoanuric period. We can control urinalysis and will see pathological elements as protein and erythrocytes, which pass through the membrane of glomeruli, which normally impossible. Health urine are free from protein and erythrocyte. Protein which pass through the tubules will be revealed with specific cylindric shape. We are talking about cylinderuria. Blood analysis show increased level of toxic substances, urea and creatinine, about which I said you, and we can control specific Reberg test, which I use for diagnosis of renal failure, which shows progressive decrease in glomerular filtration rate and coefficient of reabsorption, which show affection of glomeruli and tubules. Second stage is critical stage, and to help of our patient will immediately must send him on hemodialysis, because patient will die from intoxication. And after that, maybe only 2 ways. If procedure was not effective, we lost our patient due to death, due to intoxication. If the procedure will be effective, patient go to next stage and will help wait his recovery. Third stage, polyuric, which is positive effect of our preceded hemodialysis treatment, and it's manifested with comeback kidney to urination. Diuresis suddenly or gradually increases. As a result, concentration of toxic substances into the blood decreases because they will be removed with urine, will be decreased edema, will be restored to normal water electrolyte balance, but one problem. Excretory function of urine will be restored earlier than concentrated function, and specific gravity of urine will be low. And which may be come back to norm from 3 to 12 months from the beginning of disease. For this purpose, will include fourth recovery stage, during which patient normally urinate, no significant problem, but analysis of urine reveal its low specific gravity. And if specific gravity not normalized during this period, we are talking about formation chronic renal failure. If the specific gravity normalized, we said about normal excretory and concentration function of urine, and patient will be assessed as completely healthy. Chronic renal failure develops of other way, and it develops slowly, and during its development will distinguish three periods. And I'll pay your attention from today's lecture. Every lecture will talk about any dysfunction of vital organs. We started from kidney, then we'll talk about lung, heart and liver dysfunction. And for any chronic failure is characteristic same order, it divided on three periods. And if you understand, you will easy answer on exam. Initial period, invisible, which may be revealed only with specific methods, which are characteristic for different organs. Second stage, manifested or pronounced, which are visible. Patient feels some problem, doctor can reveal some visible signs of pathology. If we are talking about chronic renal failure, manifested pronounced period divided on two steps. First of all, polyuria, then oligoanuria. Opposite development from acute. And third, final stage, terminal period, when except main organs in pathological process will be involved all other organs and system. It is principles dividing of chronic failure on three stages. Initial invisible, second visible, and third terminal because involvement other organs. Diagnosis of renal failure will based on the disordered functional activity of kidney. Initial period, no clinical symptoms, but doctor periodically sends the patient on specific examination to reveal progression disease on early stage. Will control blood analysis to reveal early anemia because disordered synthesis erythropoietin. Will control urinalysis because low specific gravity indicates about decreased concentrative activity of kidney. As a result, in the blood will be increased level of creatinine and decreased glomerular filtration rate. I'll pay your attention. Main objective index of renal failure is decreased glomerular filtration rate. Second manifested period will be visible when the 30% of functional nephros will be lost. You see, kidney as the liver has high compensatory ability. As a result, we'll see signs of renal dysfunction. And first of all, patient feels some problems due to progressive intoxication, due to increased edema and uncontrolled blood pressure. Other words, we'll see all signs about which we said in diagnosis acute renal failure. Disordered diuresis, first of all polyuria, then oligoanuria. As a result, intoxication, edema, uncontrolled blood pressure. On examination, we'll see pale skin due to anemia, increased blood pressure, edema, will reveal decreased diuresis, and all laboratory indices will be more significantly deviate from norm than in initial period. progressive anemia, progressive increased creatinine, and decreased glomerular filtration rate and diuresis. Final terminal period manifested with involvement other organs and system. I want that you remember and understand it. As a result, condition of the patient becomes more heavy. No adequate urination. Patient in oligoanuric period. It shows that toxic substances except urine will be removed through the other organs and system. First of all through the skin and then through the mucus of respiratory and digestive system. As a result, skin becomes pale. It's a result of anemia. Sometimes with icteric thing due to delay of urochrome. It is dry because urea, which will remove through the skin, decrease its elasticity and will be illusion of powdered skin due to collection of urea crystals on the skin. As a result, patient feels severe skin itching. Doctor reveal scratches on the skin. I want that you differentiate sensation of patient, which I set as complaint, and visible signs of disease, which assessed as inspection. And we can see hemorrhagic skin rash due to affection of vessels and disordered coagulative blood properties. I said you except skin, urea will be removed through the mucus of respiratory and digestive system. As a result, mucus becomes dry. From the patient will be specific uremic breath and respiratory system predilected to secondary inflammation. Patients sick with laryngitis, bronchitis, then pneumonia and other problems. Digestive system also, mucus becomes dry, activity of gland decreases as a result due to formation uremic gastritis. Patient complains of nausea and vomiting. Due to involvement of intestinal mucus, uremic colitis, patient predilected to diarrhea, and dry mucus predilected to ulcerous and necrotic affection. Grave complication is gastrointestinal bleeding. Liver, early involved in pathological process as a compensatory organs for preventing of detoxification. Liver and kidney, both organs which control and hold our organism from intoxication. Cardiovascular system involved in pathological process. First of all, heart affected due to progressive hypertension. Then due to affection of mucus with urea will be uremic pericarditis. Due to disordered electrolyte balance, different types of arrhythmia. Due to disordered water balance will be congestive heart failure. Will afraid grave complication of heavy arterial hypertension, which assessed as acute cardiovascular situation. It is myocardial infarction, it is brain stroke, apoplexy, and loss of vision. Central nervous system early involved in pathological process because it's very sensitive to any intoxication and disordered blood circulation and blood pressure. On early period will be inversion of sleep, later will be encephalopathy, patient cannot control his emotion, and later will be uremic polyneuropathy because except central nervous system will be involved peripheral nervous system due to electrolyte, vitamin and water balance disorders. Terminal period of renal failure manifested with progressive decrease diuresis to complete anuria. As a result, progressive intoxication, which manifested with progressive disordered consciousness from the irritation, depression, then stupor, sopor, and coma. From the patient will be specific uremic breath from breathing, from skin. We can see different hemorrhagic complication, skin rash. I said you about gastrointestinal bleeding, urinary bleeding from the woman, uterus bleeding, nose bleeding, progressive edema to complete anasarcom, and more grave, which is brain edema, which additionally depress activity of central nervous system, then critical hyperkalemia, and finally uremic coma. Same finish as for acute renal failure, but time. If acute renal failure developed during some weeks, some days, chronic renal failure progresses some years. Same helplessness hemodialysis, but other types of apparatus for chronic than for acute, because each is long-standing manipulation during which patient will wait transplantation of kidney because his kidney unable to control itself function. That's all information about kidney, and we'll go to next organ. We'll again come back to respiratory system, but now we'll combine all our preceded knowledge and formulate pulmonary syndromes. Patient with pathology of respiratory system, when you will answer on the questions about pulmonary syndromes, your answer must be with definite order. First of all, physical examination, which is result of inquiry, inspection, palpation, percussion, auscultation. Then, some instrumental data for respiratory system, they are result of X-ray and computer tomography. If bronchus involved in pathological process, will prescribe bronchoscopy, and for assessment functional activity of lungs, pyrography. And laboratory method for the patient with moist cough, sputum analysis, for the patient with hydrothorax, examination of pleural fluid. It is plan of your answers on exam about pulmonary syndromes. And we'll start from syndromes which actively involve alveoli in pathological process. We are talking about consolidation of the pulmonary tissue, which is characteristic for second stage of lobar pneumonia, for progressive pneumosclerosis, for lung infarction, and compression atelectasis. Alveoli excluded from breathing because they filled with inflamed liquid in pneumonia, blood in lung infarction, they collapse in atelectasis, and restricted activity due to growth of connective tissue pneumosclerosis. In all cases, part of the lung loses airness, becomes density, which is characterized with definite signs. First of all, patient problem, patient complaints of dyspnea. It will be more intensive, the more lung parenchyma will be excluded from breathing. Inspiratory dyspnea, because no space for air inhalation. On inspection, we can see asymmetry of the chest. If the pathological process localizes in lower lobe, we can see protrusion on this part of the chest. And during dynamic examination, we can see thoracic lagging on the affected side. But again, you must understand, each is characteristic for lower lobe pathological process. On palpation, increased vocal fremitude, because density of tissue easy transmit sound. On percussion, dull sound, and restricted mobility of the lung bodies, if in pathological process will be involved lower lobe. On auscultation, pathological bronchial breathing and increased bronchophony. Each is physical examination of patient with consolidation of lung tissue. Inspiratory dyspnea, increased vocal fremitus, dull percussion sound and bronchial breathing. I want that you compare diffuse and focal consolidation. When in pathological process involved only some lung segments, we are talking about lobular or segmentary pneumonia, and CS will be different clinical picture. Maybe dyspnea, but insignificant because lot of lung tissue which can compensate small pathological foci. No visible signs, but on palpation may be revealed weakened vocal fremitus, but you must remember only in case superficial location pathological process and if its size more than 5 cm in diameter. Will be dull sound on percussion because combination of health and affected side. On auscultation will be weakened vesicular breathing because present alveoli, but its functional activity restricted with pathological foci, and depending of disease may be dry or moist rails. You see clinical picture softer, on contrary from lobe process. Main method examination of this patient is instrumental and laboratory, but I want to explain you this syndrome on example of pneumonia, which depending of origin divided on community acquired, which appears at home, and hospital, which is characteristic for the patient which long time treated in hospital, will be on long-standing bed regimen, and due to decreased activity of the breathing and some preceded pathology, secondary infections very easy affect organism, and any pathology complicated with hospital pneumonia. It may be different etiological factors, bacterial, viral, fungus. Now we'll know that main complication and main manifestation of COVID infectious is virus pneumonia. You see alveoli affected. Into the alveoli will be hold pathological inflamed mucus as protective response of organism on any invasion, but activity of alveoli progressively decreases. Pneumonia may be characterized with some pathological syndromes. First of all, inflammatory syndrome, which is characterized with moist cough as response of respiratory tract on inflammation, fever, high fever accompanied with chill, and sometimes maybe chest pain. If our patient with lobe pneumonia, the sputum has specific ruddy color because its result secondary heart failure, because density of the lung increases, blood flow through the decreases, will be overloading on the right heart ventricle, blood congested into the lung, easy absorbed into the alveoli and mixed with sputum, which gives specific ruddy color. Chest pain is result involvement of pleura in pathological process if the pathological process localizes nearest plural lay, superficial location. As a result, may be dry or moist pleurisy, but only dry pleurisy manifested with pain, moist pleurisy, painless process. Intoxication, because bacteria or virus are foreign body for our organism. Intoxication manifested with progressive weakness and excessive sweating, especially after physical exercise. About consolidation pulmonary tissue, I said you. It's characterized with specific complaints, percussion, palpation, and auscultative signs, and lung failure manifested with dyspnea. Because main function of lung is breathing, disordered breathing due to its dysfunction. X-ray examination shows signs of consolidation. In this case, dark spot localizes in upper lobe of the right lung, which indicates about upper right lobe pneumonia. This patient has upper left lobe pneumonia and medium right lobe pneumonia. Examination of sputum will find signs of inflammation in the respiratory system. Each is characterized with specific color, yellowish or green, change consistency, progressive viscosity of sputum, objective signs presented of leukocytes and alveolar macrophages, active leukocytes. Sputum obligatory examined on bacterioscopic analysis to reveal etiological factor and prescribe specific antibacterial treatment. Next syndrome, which also appears due to affection of the alveoli, we are talking about cavity in the lung, which appears due to destruction of alveoli. It may be result of the lung abscess or tuberculosis due to specific bacterial invasion, Staphylococcus and Streptococcus, which synthesize specific enzymes which destroy alveoli. And Mycobacteria tuberculosis also has same destructive properties. First of all, invasion, then destruction of lung tissue, and when the organism adequately responds with formation of connective tissue coating to separate pathological process from the healthy lung, we are talking about formation cavity. This process divided on 3 stages. You see lung after section with active destruction, which not correlated with active life. I said you, formation of cavity go through the 3 stages. First of all, active destructive process, then response of organisms with formation of coating, which opened only into the communicated bronchus, through the which will be removed all its content, and at last formation of empty cavity. During this period we can reveal next pathological syndrome: inflammatory syndrome, intoxication, destruction, and lung failure. Inflammatory syndrome manifested with cough, fever, and chill. Intoxication, weakness, and sweating. Lung failure with dyspnea, destructive process manifested with into the analysis of sputum and instrumental examination. First stage, initial bacteria invasion accompanied with destructive process. and formation pathological purulent foci, which resembles focal consolidation of lung tissue. Patient complains of signs of inflammation and intoxication. You named group complaint, which is characteristic for this syndrome, which was explained 1 minute ago. On palpation will be weakened vocal fremitus, on percussion dull sound, on auscultation weakened vesicular breathing. And at the beginning of this pathology, our primary disease may be lobular pneumonia, which such symptoms will start tuberculosis and lung abscess, and only intensive intoxication and inflammation, which is not characteristic for usual development of lobular pneumonia. Pay attention of doctor on inflamed destructive process. On X-ray examination will reveal dark spot in the projection, on this case lower lobe, segmentary pathology. Same process will be revealed on computer tomography. You see dark spot in the projection of one and other lung. Second stage, organism responses on pathology, separate it with formation of connective tissue coping, which opened only into the communicated bronchus. And we are talking about second stage, when the contents of cavity actively removed from our organism. As a result, patient complains of expectoration of purulent sputum with large amount and specific unpleasant odor. On inspection, we'll see forced position. Patient regulate process cleansing of cavity. He want to sleep, lie down on affected side. He want remove on health side. Да. У меня до 1:30 лекция, где-то ближе к 2. Да. On palpation will be weakened vocal fremitus. Percussion reveal dull tympanic sound because combination liquid and air, and it will be more intensive than more empty becomes cavity. On auscultation will be bronchial breathing with moist trails because no alveoli destroyed. It shows that cannot be vesicular breathing. And through the communicated bronchus will have bronchial breathing with moist rails because content of the cavity is liquid which expectorated with sputum. You see forced posture of patient on affected side. Patient becomes expectorate sputum, which shows active inflammation because greenish color, viscous consistency, which is rich with leukocytes. We reveal signs of destruction because we'll find elastic fiber and erythrocyte due to destruction of vessels. We see signs which show that sputum long time was held inside the body because large amount, specific unpleasant odor, presence of Dietrich plaques and cholesterol crystals indicates about destruction and activity of bacteria. Bacterioscopical analysis show etiological factors, each is Staphylococcus, Streptococcus invasion or invasion of Mycobacteria tuberculosis. On X-ray examination, we'll see above the liquid content air, more clear cavity. Also we see cavity with level of liquid and air above it. Same process, upper lobe of left lung. Also upper lobe of left lung. Same information on computer tomography. You see cavity which only opened. Then process. Cleansing of cavity continuous, and we see more or less level of liquid. And last stage, when the patient will be discharged from hospital but with destroyed lung, with empty cavity. Complaints of the patient will depend from the size of cavity. If insignificant, patient subjectively may be healthy. Then more size of cavity, then more intensive dyspnea will be. On palpation will be increased vocal fremitus because empty cavity is resonant for the air, for the voice. Percussion reveal tympanic sound. On auscultation, bronchial, sometimes amphoric breathing if the cavity is smooth and large, and intensified bronchophony. Final stage, destructive process with formation of cavity. X-ray examination reveal empty cavity, will see only its connective tissue coating. Now you see this patient will have significant dyspnea because all right lobe destroyed. Next problem with alveoli, but its origin into the bronchus. We are talking about syndrome of bronchial obstruction with formation obstructive atelectasis. You see on the picture when main bronchus obstructed due to growth of tumor. Sometimes it may be obstruction with foreign body, which more typical for children. As a result, non-ventilated alveoli gradually collapse, and we are talking about formation obstructive atelectasis. Complaints of the patient: inspiratory dyspnea and dry cough due to irritation of bronchus with foreign body. On inspection, we can see asymmetry of chest with diminished affected side and thoracic ligand. On palpation, first of all weakened and then complete absent vocal fremitus, when the bronchus will be completely obstructed. On percussion, dull tympanic and then dull sound. I give you two characteristics at the beginning and at the end, formation of obstructive atelectasis. On auscultation, weakening and then absent breathing and bronchophony. You see that some sides of the lung completely excluded from breathing. You can compare health patient and patient with obstructive atelectasis, visible asymmetry of the chest. Next syndrome. It's characteristic for pathology of pleura. And we distinguish two pleural syndrome, hydro and pneumothorax. Hydrothorax, collection of liquid into the pleural cavity. It may be inflamed origin. We are talking about exudative pleurisy, which appears as complication of pneumonia, tuberculosis, or lung abscess, or subdiaphragmic abscess due to liver pathology. And non-inflamed hydrothorax, which appears due to response of pleura on any other pathology. It may be manifestation of edematous syndrome in cardiac failure, in liver cirrhosis, or response on any canceromatous process. To decide it is inflamed or non-inflamed process, we can only after puncture of pleura and examination of pleural fluid. Hydrothorax appears gradually because liquids cannot be formed during short period. As a result, patient complains progressive, gradually develop discomfort in the affected sides of the chest, feeling of heaviness, and as a result, increased inspiratory dyspnea because liquid push on the lung and provoke compressive atelectasis. On inspection, we can see asymmetry of the chest with thoracic lagging because hydrothorax located in lower part of the lung. On palpation, vocal fremitus may be weakened in initial stage and absent at the end. Same problem with percussion, may be dull or complete dull sound. And auscultation may be weakened vesicular or complete absence of breathing. All depends from amount of liquid. When lung only separated from the chest, your palm and stethoscope, or completely absent due to compressive atelectasis. Again, we'll compare health and sick patient. On contrary from preceded pathology, we see asymmetry with protrusion. X-ray examination reveals specific dark part into the pleura, and depending of line, which is called Damoiseau line, we can approximately decide question about inflamed or non-inflamed origin. If the line of hydrothorax inclined, it's more characteristic for inflamed exudative pleurisy. If horizontal, it's more characteristic for non-inflamed hydrothorax. And if you see on the patient, on affected side, you see asymmetry. Pay attention on the slit between hand and thorax. It's not symmetrical. And we also see slight protrusion of lower part of the right lung. You see inflamed hydrothorax because inclined Damoiseau line, also inflamed origin because inclined, and non-inflamed origin because horizontal line, which is characteristic for maybe heart edematous syndrome. Computer tomography also show level of liquid. It's there, we can determine its density, which also gives some information about inflamed or non-inflamed origin. But full information we can have only after examination of pleural fluid. Puncture of pleura, and you see different content of liquid, maybe rich with blood, with pus, and any other pathology. When you will interpret pleural fluid, first of all you must determine each is inflamed, effusion, or non-inflamed transudate origin. Each is possible depending level of relative density, protein, and Revolta reaction. If it's higher than 1,015 gram centimeter in third degree, protein more than 3%, Revolta reaction positive, it's effusion, inflamed origin. If low, it is transudate. If effusion, you continue your answer because you must determine its type, serous, purulent, or hemorrhagic, depending on level erythrocytes, leukocytes, and mesothelium cells. If serous effusion, it is characterized with few leukocytes and erythrocytes, but many mesothelium cells. Purulent effusion is characterized with many leukocytes. Hemorrhagic, many erythrocytes. And microbiological analysis helps you to reveal etiological factor and prescribe correct treatment. Next pleural syndrome, which is pneumothorax, accumulation of air in pleural cavity. Usually it appears due to rupture of the inner pleural layer as complication of tuberculosis, abscess, emphysema, or maybe outside trauma, which first of all affect outer layer of pleura. And you'll understand air can go in pleural cavity from outside or through the affected lung. As a result, we distinguish two types of pneumothorax: opened, when the air easily go inside the pleura and during expiration can come back. As a result, lung periodically collapse, slightly expand, and this type of pneumothorax is more easy for the patient. More grave if the pneumothorax is tension, when the air progressively increases into the pleural cavity and cannot come back. It circulates in the pleura. As a result, lung progressively collapse, and you understand if you during 1 minute we will do approximately 16-20 breathing, or due to any pathology breathing intensify. After 1 minute, patient inhale nearest 10 liters of air, which hold into the pleura. Lung immediately collapse, and it may be finished with shock or death of patient. And needed emergency aid. First of all, we transform tension pneumothorax in opened due to puncture of pleura with needle, and then it may be regulated only in surgical department. Complaints of the patient. If you remember, pneumothorax is possible only due to rupture of pleura, which is very rich with painful nerve ending. As a result, patient feels severe, sharp pain in chest. And then fast increased inspiratory dyspnea, on contrary from hydrothorax, in which only discomfort and continuously, gradually increased dyspnea. On inspection, we see as progressively protruded affected site asymmetry and lagging of affected site during breathing, no vocal fremitus, tympanic sound on percussion, and no breathing. No, you understand, it's acute situation. Will not completely use all method examination. First of all, we'll use more high value for diagnosis. We'll put stethoscope, no breathing, we'll tap 2-3 times, loud tympanic sound, it's pneumothorax. We'll send our patient on X-ray examination and we'll see no lung picture. Right side pneumothorax. Also, right side pneumothorax, no lung picture, compare with health sites. Computer tomography not used for primary emergency diagnosis because needed sometimes. It is used only for control of healthing process and revealing of pathological provoke factors, because pneuma and hydrothorax appears only as complication primary pathology, not as primary disease. Next problem on which we'll stop appears due to primary affection of bronchus and non-adequate response, which manifested with periodic spasm of bronchus. We are talking about bronchospastic syndrome, which is visited cause of bronchial asthma, which appears due to allergic process and non-adequate response on any features, on any dust, it may be home or industrial. First of all, smoking. It may be result on allergic reaction on pollen or different animals. As a result, bronchus non-adequately constricted, patient feels difficult breathing. We are talking about attacks of bronchial asthma. Main complaints of the patient is attacks of asphyxia with difficult expiration, expiratory dyspnea, because through the narrowed bronchus air easy inhaled and difficulty exhaled. To help himself, patients feel specific posture, orthopnea, sitting position with fixation of upper extremities on any stand, because right diaphragm and help expiration. Breathing of patient becomes mixed due to prolongation of expiration, which becomes same with inspiration, and due to long-standing bronchial asthma and progressive distension of lung, because patient actively inhale but difficulty exhale and dead space increases, will be formed specific emphysematous chest. On palpation, which will be weakened vocal fremitus, on percussion, bandbox sound, on auscultation, mixed respiration and dry rails, diffuse dry rails over all chest. Sometimes it may be heard on distance, which is characteristic for attacks of bronchial asthma. Palpation and percussion are characteristic for complication emphysematous chest. In initial stage of bronchial asthma, palpation, percussion and shape of chest may be normal. And only during attacks of bronchial asthma we can hear dry rails. During period of remission, patient may be completely healthy. Sputum examination, because any attacks of asphyxia finish with expectoration of specific viscous sputum, which is rich with allergic elements, allergic triads. Sputum of the patient with bronchial asthma is rich with eosinophils, Charcot-Leyden crystals and Kurschmann spirales. For diagnosis of bronchial asthma, we'll use spirometry and we'll pay attention on expiration, forced expiratory vital capacity, full or for first second, its correlation and obligatory functional test. After first expiration, we'll give the patient bronchodilators medicines and again ask him to exhale. And if first expiratory vital capacity increased more than 15% from initial level, which indicates bronchial asthma and problem of patient due to bronchospasm. It helps differentiate bronchial asthma from chronic obstructive lung diseases, which appears due to changing morphological characteristic of bronchi, decreased its elasticity and progressive narrowing of bronchial lumen. Emphysema, problem into the alveoli, but I'll talk about it after bronchial asthma because usually it appears as its complication. Rare case will meet patient with primary emphysema due to hereditary deficiency of alpha-1 antitrypsin, which characterized with decreased elasticity of the lung. More often, emphysema appears secondary as complication bronchial asthma, chronic obstructive lung diseases, and some professional diseases such as glass bowel and musician. But more grave provoke factors is smoking, because it's very rich with toxic substances which affect respiratory system and complicated with emphysema and canceromatous process. Complaints of patient, mixed dyspnea. If you was attentive during today's lecture, you can see when we said about pathology of lung and pleura was inspiratory dyspnea, bronchus pathology, expiratory dyspnea, emphysema as complication of primary bronchial disease, mixed dyspnea because both alveoli and respiratory tract involved in pathological process. On inspection, specific emphysematous barrel-shaped chest with mixed breathing. On palpation, rigidity chest because no elasticity of the lung and weakened vocal fremitus as result. On percussion, specific tympanic band box sound and decreased mobility of the lung and increased size of the lung, displacement upper and lower bodies. On auscultation, diminished or mixed respiration. It depends from what more significantly involved in pathological process, bronchus or alveoli, diminished inspiration or prolonged expiration. You see emphysematous chest, which characterized with increased anterior, posterior and lateral sides and protrusion of interspace and supraclavicular fossa. On X-ray examination, we see enlarged lung. And at last of today's lecture, I want to stop on lung failure syndrome. Again, next vital organ's lung is dysfunction manifested with failure, which may be acute or chronic depending on time. Acute lung failure appears suddenly due to severe acute pathology. It may be bilobar pneumonia, it may be trauma, it may be lung infarction, and chronic lung failure, which will be formed of the patient with any chronic lung diseases, bronchial asthma, chronic bronchitis, tuberculosis and others. Lung failure divided on some types depending of breathing changing. We are talking about restrictive lung failure when the problem with expansion of the lung, and you understand will be the problem with inspiration. Obstructive lung failure appears of the patient with affection of respiratory tract, narrowing of bronchus, and mixed when the both bronchus and alveoli involved in pathological process. Restrictive type of lung failure is characteristic for the patient with affection of alveoli. It may be result of pneumonia, about which we said today. It may be result of lung abscess with formation of cavity or obstructive atelectasis. Other cause, which is problem with expansibility of alveoli, when the alveoli cannot be expanded and collapse due to decreased elasticity, pneumosclerosis or emphysema. It may be a result of hydro or pneumothorax, inside or outside problem. And at last, outside restriction, when the expansion of lung limited from the chest and costal muscles. We are talking about kyphoscoliosis or ossification of costal cartilage, decreased elasticity of the chest, which restrict depth of breathing. A restrictive type, no adequate expansion of the lung due to decreased its elasticity, due to affection of alveoli or due to outside restriction. You see lobar pneumonia, lung abscess, obstructive atelectasis, hydra and pneumothorax and emphysema. And deformation of the chest due to any pathology of spinal cord and bones. Obstructive type of lung failure appears due to narrowing of bronchial lumen, and it's more characteristic for chronic obstructive lung diseases and bronchial asthma. Chronic obstructive lung diseases due to affection of morphological characteristic of bronchus, decreased its elasticity and progressive narrowing of lumen due to pathological growth of connective tissue. Bronchial asthma due to periodic spasm of bronchus. And mixed type appears due to long-standing diseases of the lung and involvement all its sites in pathological process, or maybe complication of chronic heart diseases. Chronic lung failure, as any chronic failure, divided on 3 stages. I said you about it when explained chronic renal failure. Same principle. First, initial stage, no visible signs. Second, manifested pronounced stage, visible. And third, terminal final stage, pronounced because involvement of other organs in pathological process. If we are talking about diagnosis of the lung failure, it's based on complaints of the patient which shows decreased activity of breathing, visible signs of diseases, and objective signs result of spirography examination. First degree, initial invisible, no problems. Patient feels discomfort only after significant physical load. No, for example, he cannot long time jump, run, swim, cannot very fast walk or go along long stretch. But usual life, comfortable. On inspection, no visible signs. Only after giving of the patient any physical exercise, we can see that respiration accelerated faster than in norm, and as a result, decelerated and come back to the norm also slowly. Usually, physiological dyspnea disappears after 5-7 minutes. Pathological dyspnea appears early, disappears longer. We'll send our patient on spirography, and we see that its data deviates from norm more than 20%. 20% is physiological deviation. If more, but not exceed 40%, we are talking about first degree. Lung failure must be diagnosed 2 characteristics, degree and type. Second degree, visible. Patient feels discomfort in breathing, dyspnea after insignificant physical load. For example, he cannot go more than 100 meters, obligatory must stop. It cannot rise more than 1 floor. It's insignificant physical activity. On inspection, after physical exercise, we can see cyanosis, bluish color of skin due to hypoxia. We can see active involvement of respiratory muscles. We see patient cannot breathe as usually. If you examine yourself, breathing invisible. But patient with second degree, breathing becomes visible because we see movements of nose. We can see movements of intercostal muscles, more high amplitude of the chest. And spirography reveals deviation of indices more than 40% from norm, 40 to 60. Third degree, patient feels dyspnea at rest and we see signs involvement of other organ, in our case which is heart, which manifested with palpitation and edema on the leg, because in chronic lung diseases, right ventricle involved in pathological process with formation of pulmonological heart, with congestion of blood in greater circulation. On inspection, more intensive cyanosis, more intensive involvement of accessory muscles, which will be revealed at rest, not needed, give the patient some physical exercise. We can see leg edema, especially at the evening, and specific first position. If the patient with first degree will sleep on one pillow horizontally, second and third degree, we can see 2, 3 pillows, and sometimes patient can be in sitting position, because any horizontal position manifested with severe dyspnea. On palpation, we can reveal false pulse, which indicates objective palpitation. We can palpate edema on the lower extremities and hepatomegaly due to delay blood into the liver. More objective information will be taken from spirography, because the data deviate from no more than 60%. Spirography indices 20 to 40, 40 to 60, and more than 60 plus 20% from physiological deviation. Spirogram may be recorded with classical method, when graph will be drawn on the paper, but last time we'll use computer spirogram. But computer spirogram resembles classical spirogram, and I want that you will be informed about it, because on practical classes we'll interpret classical spirogram, where wave indicate depth of breathing, usual breathing, each is respiratory volume, amount of air which inhaled during one breathing, time of breathing during 1 minute, which is corresponded 5 centimeters, help to count minute volume and respiratory rate, deep breathing, vital capacity, characterized elasticity of the lung, and you understand first of all it will be decreased in respiratory type of lung failure. Next, forced expiratory vital capacity, when after deep inspiration patient as possibly fast exhale, and exhalation during first second. Forced expiratory vital capacity is needed for diagnosis of obstructive type of lung failure, and each is main diagnostic index of bronchial asthma and chronic obstructive lung diseases. And at last, we'll ask the patient as possible deeply and fast breathe to control protective response, compensatory response of the lung, maximal lung ventilation. Computer spirogram will be recorded into the computer, which will count all indices and give only a result on paper, and doctor only compare definite results with normal indices. But you see it resembles also normal breathing with respiratory volume and respiratory rate, vital capacity, deep breathing, and expiratory vital capacity. Each is normal breathing, each is deep vital capacity, each is maximal lung ventilation. Patient actively breathe during short time, 15 seconds. On exam, we'll give you classical spirogram and computer spirogram, on which you must depending of which you must determine type of lung failure. It's dependent from depth of inspiration and expiration. I want that you remember lower part of graph is inspiration, upper expiration. No, and you understand restricted inspiration, restrictive type, expiration, obstructive type, both mixed type. If you see on this graph, you see patient usually inhale, but restricted exhalation comparing with non. We are talking about obstructive type of breathing. Restrictive, problem with inspiration. Patient cannot adequately inhale. And this graph show you norm. Then two next graph is characteristic for obstructive type because upper part is expiration. Next to restrictive type and last is mixed type. That's all today. We'll improve your knowledge on practical classes. Will be 2 classes on lung syndrome in spring term. But I want that you hold this information because it will be needed you for practical class and for exam. Thank you so much for your attention. Goodbye, be healthy.